Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Good morning, ladies and gentlemen. Thank you, Colonel Shackelford, for the and everyone else, of course, for the introductions and the opportunity to share with everyone this update on our telemedical support for operational environments. I think you'll find it hopefully interesting that the available services and kind of capabilities that we have previously been developing have really rapidly grown and are starting to harden for long-term viability ever since the establishment of the new virtual medical center at Brooke Army Medical Center. As Colonel Shackelford said, my name is Lieutenant Colonel Jeremy Pamplin. I'm currently Director of Virtual Critical Care and Virtual Health at Madigan Army Medical Center. And then, although not an official title, I've been working for the last couple years with certainly many of the people on the line, and as well as others, as the medical director, developer of the first virtual critical care consultation service, and subsequently the advanced virtual support to special operations system, which we'll talk more about here as we move forward. I should also say that we are trying to record this conference this morning for one of the prolongedfieldcare.org podcasts. So this will maybe sound a little bit more scripted than some of my normal conversation that was told to stick to the script as much as possible. And then at the end, when we do our questions, I will probably repeat any questions that are asked. So next slide, please. Of course, the views and opinions that I express today are those of my own. They don't reflect those of the United States Medical Department, Army, the Department of Defense, the U.S. government, and my only financial disclosures to share that I've received grant funding for several projects from the Medical Research and Material Command through the Telemedicine Advanced Technology Research Center, as well as Joint Program Committee 1 and Joint Program Committee 6. So this is a build slide. If you want to just build a couple through, that would be great. Yep, perfect. So first of all, I'd like to start by reviewing a couple cases that I think some of you on the line may be already familiar with. At least one of them has been presented on the JTS conference several months ago. I think they highlight the potential value of telemedical consultation during the prolonged field care or delayed evacuation or extended care, prolonged care, whatever you'd really like to call pre-hospital care by a non-specialist that extends beyond our current doctrinal timeline, so more than an hour's worth of care. The first case occurred in April of 2017 when a Portuguese coal freighter, the Tomar, experienced a confined space chemical explosion in the middle of the Atlantic Ocean. This explosion injured 4 of their crew members, and without any medical capabilities aboard the ship, they requested emergency medical support. And the New York Air National Guard 103rd Rescue Squadron was mobilized to respond. By the time the team had arrived, 2 of the casualties that were aboard the ship had died. The remaining 2 casualties had suffered 60% total body surface area burns, and the team that jumped in needed to manage them for nearly 36 hours while the ship had made its way towards Portugal. During that time, this team of PJs provided, amongst other things, IV fluid resuscitation, wound care, escharotomies, and a cricothyrotomy for one of the casualties. And throughout this encounter, I think it's probably useful to note that the team maintained really regular contact with their unit surgeon, who provided recommendations and sometimes just support for many of the team's interventions and medical decisions. And this surgeon also used personal contacts at the U.S. Army Institute of Research Burn Center for some of his recommendations that he made to his team. Next slide, please. The second case occurred in May of 2017 in Cameroon, West Africa. In this scenario, the task force physician, so the most senior medical person on the ground, actually developed symptomatic supraventricular tachycardia. And unfortunately, given the limited experience of the remaining medics that were on the ground with him at managing SVT, they contacted the U.S. Army Africa surgeon, one of the PAs, who then, again, through kind of personal knowledge, called the Brooke Army Medical Center Emergency Department in order to get some additional recommendations about how to manage this SVT. Ultimately, the patient did reasonably well, but in the after-action review by this group, the team recommended that a telemedical system that had on-hand a network of subject matter experts and that could provide assistance to outstations with medical emergencies would be useful. And the team furthermore kind of said they thought this telemedical system needed to be accessible to all personnel and not only medical personnel. So clearly next slide please, clearly these two events demonstrate that an operational need for some form of telemedical support exists, or the requirement for reach back for care for the ground to achieve specialty expertise would be valuable. The challenge is, in this case, really neither of the teams use some of the formalized systems that currently had existed at the time. Instead, both of them used some of their medical chains of command for help, and then also circumstantial support from friends or relationships they had developed informally. Excuse me. And while these kind of informal relationships can be useful, certainly they are common across medicine. We all experience them during our training. They are kind of fragile solutions to achieve medical consultation because they're really dependent upon the individual personalities of the care providers that are involved, as well as those relationships with or knowledge of how to access the right expert at the right time. I think everyone on the call is understanding that we have been, this is the next slide please, have been challenged to win a complex world by the new Army operating concept. But the real question is how do we as a medical team support or optimize combat casualty care across such a diverse spectrum of care environments using really the highly variable and oftentimes very limited medical resources and sometimes inexperienced caregivers who might oftentimes have a great breadth of knowledge and really some exceptional skills, but they may have limited depth and or experience with taking care of specific diagnoses or problems. Next slide, please. So I think that this is the purpose of this conversation today, that telemedicine is one possible solution to this problem set, and that's what I'd like to talk to you all about today. The review, the outline what we're going to talk about is shown here. I think I'm going to spend a little bit of time boring you all first with some of the definitions that exist with telemedicine, because I think, frankly, telemedicine is quite new to our culture, certainly new to the kind of environment that we do our medical care in. So it's worth having a common operating picture with some specific definitions. Then we're going to talk a little bit more about some of the solutions, why we're developing these solutions now, some of the solutions that currently exist, and hopefully some practical take-home points for the group. So what is telemedicine? Telemedicine is the remote evaluation and diagnosis, treatment, and or consultation using telemedicine technologies. Asynchronous communication is one way, or unidirectional, often time-delayed communication, and examples of this are text messaging and emails. So one of the key questions, of course, we need to answer is why haven't we been focusing on this problem set before? And if you continue to build, the answer is before around the 2013 drawdown of forces in Iraq and Afghanistan, most of our pre-hospital care was limited to less than an hour. And this is certainly a problem set that most of our new or general practitioners like our medics are comfortable with. And certainly most of the consultative support that was done in this environment was provided by local and in-theater assets through those types of personal relationships developed on the ground. Next slide, please. So our challenge now and in the future is really the tyranny of distance. Many people have seen either this slide or one similar to it. The original one was developed by Colonel Sean Keenan. The current anticipating operating environments of our future really are big: Africa and the Pacific Rim, whereas Iraq and Afghanistan can easily fit in the United States of America, really just in the central United States. The entire United States fits into the northern part of Africa. And if you ever looked at one of the maps of the Pacific Ocean, all continents of the world can sit inside the Pacific Basin. So where it used to take less than an hour for us to reach advanced surgical and critical care support, now those resources are more on the 24 to 72-hour timeline following a prolonged evacuation. Our medical footprints are getting smaller with these areas of operation that are getting bigger. Our very well trained and sometimes inexperienced or unknowledgeable medics, not because they haven't been training hard, but let's face it, you really can't train on everything. You can't know everything. But these folks are forced to care for patients really over a lifetime and with problem sets that they haven't previously encountered. Next slide, please. Of course, most people are familiar now with the concept of prolonged field care. This is an operational problem. It is not a plan, so it's something that we do not plan to do, but is a situation that we are found in, and therefore it should be planned for. I'm not really going to spend a lot of time talking about what prolonged field care is or what it's not, who should be performing it, who shouldn't be performing it, because it's a reality that many people face, whether they were intending to or not, and the reality is we can't evacuate our casualties maybe as quickly as we would like to. If you need to know more or would like to know more about this problem set and how to manage it, I would certainly refer you to the prolongedfield.org website. You can see at the top of the PFC symbol there. They've got a wealth of information on that website, including the 10 core capabilities, podcasts, blogs, links, and other references. Next slide, please. One of the key points of prolonged field care is that you have to survive beyond the initial injury in order to get to the prolonged field care aspect. So important to all prolonged field care is the emphasis that it is built upon a foundation of excellent tactical combat casualty care, something fortunately most of our medics and caregivers are familiar with these days, and usually exceptionally good at. Unfortunately, it's more difficult to train and educate our folks about the myriad of problems that can occur in the hours and days following the acute trauma or illness. And it's in that window that prevention of complications is key, and sometimes experience and prior training for these kinds of challenges, like with critical care or surgical training, certainly helps. Next slide, please. And it's in this environment, again, that I think that telemedicine really may be able to aid the caregiver on the ground as it bridges a significant gap in knowledge and experience between local caregiver and the next higher level of care. It's important to be clear, though, telemedicine is not Plan A. Plan A is to train and to educate our clinicians and to deploy, when possible, the necessary resources to care for the casualty at the point of need. And if you have ever heard, again, Sharon Keenan speak, he always says that if you think you might need a surgeon, you should bring one with you. So the challenge that we're faced with, of course, is when you don't have your surgeon or you don't have the resources that you might need because you can't deploy everything. So there does need to be a plan B, and that's where telemedicine hopefully fits in. Next slide, please. I should also be fair. There are some potential advantages of telemedicine, maybe even over our traditional deployment mindsets. If a system is implemented correctly, it may offer us to have a smaller footprint of certain medical assets or certain medical personnel. So maybe a less deployment that could be potentially cost savings. An example of that might be if you are able to train technicians or medics to help with certain types of exams, like an ophthalmologic exam or dental exam, using remote telemedicine technology solutions. You might not have to deploy an ophthalmologist or dentist to all of the current locations that they're being deployed to. And in that context, telemedical support can actually improve access to certain types of care providers. And certainly if the network infrastructure, and I mean the communications infrastructure, is robust enough, it could be possible for a remote expert to quote unquote see a soldier or a service member at a remote outpost without the need for them to be evacuated. And this could reduce some of the unnecessary medical movements that we have both in theater and out of theater. Next slide. Unfortunately, if history is going to prove itself correct, and it usually does, the myth of having robust, highly reliable, large bandwidth, low latency, and a fully functioning communication network in any of our future engagements is likely to occur. Certainly, we don't have those types of infrastructure now, and because Murphy is ever present in our operating environments, should be anticipated that our communications will ultimately be vulnerable and certainly could fail. Not that we shouldn't anticipate that the technology will be available at some times, and we should plan for that. But I just want everybody to consider for a moment the last time they tried to either FaceTime or Skype or do a video teleconference with a family member. And now I want you to think about whether or not it worked perfectly as designed. And if it works perfectly every single time as designed. And of course, the answer is that it doesn't. Even though that system is operating on a pretty robust and fairly well-maintained cellular network or internet network infrastructure in the United States. The reality is that in these social situations, many of us don't even take notice of this problem. We just switch to a phone call, or we say that, hey, mom, dad, grandma, grandpa, I'll just call you right back, or I'll call you back later. But of course, that's not an acceptable solution for medical support for our casualties. Next slide, please. So I think many of us are recognizing that this is a challenge, and we're working to develop solutions to these communications problems by exploring automation, robotics, and potentially artificial intelligence that could provide some of the advanced medical care or clinical decision support where there is no expert available. But these solutions are certainly still in development, probably on the range of 10 to 20 years away from being ready for prime time. And in that case, I think telemedicine really may be able to fill the gap of the knowledge and expertise. Next slide, please. One more slide. Okay, so what are some of our current efforts and capabilities? One more slide. One of the ways to think about this problem is in terms of what the medical assets or medical needs are that must be supported by telemedicine. This is now becoming a slightly older slide. Some of you may have already seen it. And it was developed after Major Jeff Della Volpe and I reviewed a year's worth of the asynchronous consultations through the Office of the Surgeon General's email consultation system run by Chuck Lappin. As one might expect, the majority of need is routine problems that can probably be handled by an asynchronous solution, in this case, the email consultation system. Other problems, however, due to medical conditions and or communications available. So if you have a limited communications window, you may have a more urgent or even emergent need to get consultation. And those types of scenarios really require a synchronous telemedicine solution. Still, some other problems as you move up the pyramid might benefit from a continuous engagement of the remote experts, say a critically ill trauma patient who needs to be evacuated. That patient may benefit from ongoing monitoring by a critical care nurse or a physician while awaiting the evacuation, or even potentially during the evacuation. And this might be able to limit the way that we currently use some of our high-value medical personnel in the local theater. Whereas now we currently will oftentimes send the most experienced provider on a medevac with a patient if we were able to remain continuously engaged with that patient from a remote location with experts. Perhaps that high-value medical personnel could stay at the point of need rather than having to get on a medevac and accompany a patient. Finally, the very top of this pyramid looks to be related to procedural telementoring, which is when a local caregiver needs to perform a life-saving intervention. Maybe we'll say something like a chest tube, but really has limited experience in doing so. Maybe they've never done it on a live person before. And this type of a problem set has been actually demonstrated by the Israeli Defense Force to be feasible for using or amenable to using augmented reality to successfully coach both trained and untrained novices through that procedure. So they've been able to take trained and untrained, basically medical students to perform tube thoracostomy using telemedical solutions. If we go to the next slide, it looks blank. If you could build that all the way to the time you have a red line across the bottom, that would be great. So our military healthcare system over the last 10 to 15 years, one more build, has been developing several telemedical solutions to support operational forces really over the past 30 years. The ones that are shown here are from the past really about 10 years or so. They certainly don't include all the efforts that exist, but they are at least a sampling of what has been available for the last several years. They include asynchronous solutions at the top, such as the AKO or OTSG email consultation system that probably nearly all of us have used at one point or another, to also the more recent Pacific Asynchronous Telehealth portal and the Health Experts Online portal. Those two solutions, many don't realize, but they're actually the same technology. They're even the same computer servers, both of which are actually housed at Tripler, but they are managed by two different teams, one at Tripler and one at Portsmouth. We have more recent efforts, certainly some of which I've been a part of, to provide synchronous support with telephone-based solutions like the Virtual Critical Care Service or the Advisor, the original Advisor system, to also having some of the video teleconsultation or video solutions like the Telehealth in a Bag system that was developed at Launchstool, which many of the folks in Africa have been using. A similar video consultation service was used by the synchronous telemedical support to Special Operations Forces, or the STS-3 solution that used something called Web or Real-Time Communication Software, and that was a project primarily with 5th Special Forces Group out of Syria. The most recent effort has been developing procedural telementoring with a battlefield emergent stabilization skills trial that is currently being conducted by some of the folks at Fort Bragg as well as Womack Army Medical Center, so 3rd Group and Womack, and they're going to be examining augmented reality and other telemedical technologies to support procedural telementoring. So usually when I show this slide, people think that it's a lot of options and rather confusing. I do too. So it's good to know that we have made a lot of progress since the VMedCen has started, and we are trying to simplify those solutions. So if you go to the next slide, please. We now have the Advisor system. The Advisor system, as it currently stands, integrates all of the previous telemedical solutions that I had on that last slide into one program that is anticipated to be core or PALM funded in years to come. In this system, all urgent and emergent consultations are routed through an automated phone system to reach a specialty consultant in real time. And routine consultations are still managed by either the AKO email system or, where available, so this is primarily CENTCOM and PAYCOM, the PATH and HELP portals. We are working towards bringing all the routine consultations into the PATH HELP system, but that is not quite ready for prime time. If you go to the next slide. This slide shows the current telephone tree of how Advisor works. If you call one of the either toll-free number or DSN number that's at the top of this slide, you are connected with an automated system. If you press option 1, you're connected to the Virtual Critical Care Consultation Service currently, and hopefully in the relatively near future, we will be connected to the Joint Telecritical Care Network workstation that is on call, and I'll talk about that in just a moment. If you press 2, you are directed to the Specialty Services menu, so it's a secondary menu, and you are provided options for talking to a general or trauma surgery physician, an orthopedic surgeon, a pediatrician, a toxicologist, or an infectious disease specialist, and then there's a option on that menu for kind of catch-all if you need a specialty that's not otherwise listed. If you press 3 from the top menu, you're actually directed to one of 3 on-call emergency rooms, and we have just added number 4 option, which if you press it, you're directed to the U.S. Army Burn Center. Hopefully in the very near future, we'll also add an option number 5, which will be connecting folks to the acute lung injury team or the ECMO service that's now at San Antonio. Next slide. And this next slide is really more for situational awareness than for anything else, because many people have asked questions about this program or this effort. So the critical care community across the military health system is working to create a joint telecritical care network, or a JETSON, in an effort to provide really more reliable telecritical care services to both MTFs and for operational forces. And it's anticipated that once these workstations are online, staffed 24/7, that we'll have at least the opportunity to start trying to provide continuous remote casualty monitoring. Slide. We hope that this platform, the JETSON, will be able to provide both readiness and sustainment training for our operational and our garrison telemedicine providers as they support combat casualties. And if you go to the next slide, conceptually that allows us to train as we fight in the TDA and TLNE worlds. Next slide. So bringing it home, we're going to talk about some practical take-home points for operational telemedicine. First, I need to try to dispel a few additional myths about telemedicine, particularly in the operational world. So the first one is telemedicine is not only video teleconferencing like a FaceTime or a Skype. It is really something that we do in medicine every single day and really all the time. It's picking up a phone, it's writing an email, it's sending a text, it's just asking for help. Telemedicine, asking for help with telemedical consultation is not a sign of weakness. Asking for help about something you're not an expert in or have strength in is really a sign of strength. It's called doing the right thing and having good judgment. So I am certainly not a kidney doctor. I'm not a liver doctor. I'm not an infectious disease specialist. And when I run into situations that I'm not certain about or perfectly clear about how to manage, I ask help. And I think that really everyone else out there should too. Good telemedicine is actually not easy. Asking for help efficiently and effectively and then providing it from a remote location are skills, and they take practice, and we need to continue to train them. Many people who have participated in some of the soft training exercises have experience of that firsthand. And then finally, this is really more for some of the providers that are out there. If you give the best advice that you can with the information that you have available to you, you are not liable for the outcome of that casualty or that patient. Ultimately, the local caregiver is responsible for the patient's care, and you can only make the best decisions that you can and give the best advice you can with the information that you have available. That being said, I highly encourage people to document what information is provided to them at the time of their consultation and what recommendations they provide with that information. And ideally, you should try to send that documentation in whatever form it is, usually it's an email, to whoever is making the consultation to you. Next slide. Several of us have tried to capture our lessons learned over the past few years in this teleconsultation and prolonged field care position paper that was just published in this fall edition of JSOM. And I'm going to try to quickly go through the 4 main recommendations from this paper. Next slide. First of all, planning. So providers should develop a teleconsultation pace plan before they deploy, not afterwards. That plan ideally should include the who to call and the how to communicate them. That plan must remain flexible, and it should adjust to the available local theater and strategic medical and communication assets that are available. Communication solutions within this plan should include and not be limited to commercial and tactical options. And I think this is important because you'll find, again, Murphy rules in that whatever communications platform you plan for may or may not be available when you actually need it. The remote consultant and or the expert that is available to call could certainly include the advisor system now, but you should also consider other medical assets in the chain of command, the theater of operation, the area of operation, to include surveyed and approved local hospitals and coalition forces. So don't forget to reach out and interact with the friends that are nearby. Units should test and train this plan whenever possible, both before deploying, and should do the communication checks after they have deployed. Next slide. Training is important for this telemedical solution. Local caregivers and remote consultants need to train to provide optimal care using various telemedical technologies, including phone, video teleconferencing solutions or softwares. They need to practice doing remote ultrasound guidance whenever possible, and whatever other scenarios they feel that they may run into, like procedural telementoring. This should consist of both classroom and, whenever possible, practical exercises. Next slide. When you're doing your practical exercises, you should try to include in that training various levels of patient complexity. So doing a consult on a simple patient is much different than doing one on a complex patient. And when you incorporate critically ill and or injured patients into the exercise, it becomes even more lifelike and valuable training. Certainly some of that training takes a lot of time, so we have provided some options for how to potentially structure or scale that training according to the minimum, better, and best kind of model. And if you want to read more about that, you can look at that in the position paper. One of the things that we found useful and important is that is this prep mnemonic. One of the challenges I think that faces our medics and some of our general practitioners out there is the ability to ignite telemedicine. And what I mean by that is that oftentimes people are not willing to make the phone call. So the PrEP mnemonic, which stands for preparing, recognizing, executing, and performing, is one way to structure some of the training that you conduct, and that may ensure telemedical consultation is optimized. Again, good teleconsultation begins. Sorry, it's early in the morning here, and we have an alarm going off. Good teleconsultation really does begin with a team that's well prepared to perform the teleconsultation task, and using the PrEP mnemonic can help people get there. I think that recognition, I just want to highlight recognition. Recognition is probably one of the most important aspects of this mnemonic, and recognition of the need to perform teleconsultation begins when the person on the ground realizes that they have a question to which he or she just doesn't know the answer. So as soon as you recognize the need for help, you should consider making a phone call, make the phone call early, and make the phone call often. Another aspect that I think is worth highlighting is that the consultation, to be most effective and efficient, should use a script or telemedicine script that is completed and before the consultation is made, and ideally trained with before deployment. An example of that script is available at prolongedfieldcare.org, and that script has been tested in well over 100 training scenarios up to date. If we go to the next slide, we do have this is actually the VC3 call script, and we have a guide for it. Again, it's available at prolongedfieldcare.org. Just keep going. Next slide. There we go. Keep going. Another slide. That's the front side of the script. If you go to the next slide, you can see that in this guide there is some guidance about how to use that call script. Keep going. You have the back side of this call script, and then one more slide, and that's the instruction for how to use the back side of the call script. Okay. A question is often asked, what's the best technology to use for a teleconsultation? And the reality is that you should use the best one that's available that optimizes the consultation at hand. But you should also realize that technology is a tool that is used for teleconsultation. It's not a requirement for it. So you really should not waste your time or your resources establishing some, high-end, very special video teleconferencing solution if a lesser, more available technology like an email or a phone call is sufficient for the consultation at hand. So if you don't need special technology, certainly you don't need to use it. And obviously, if you don't have that network infrastructure available, you may not be able to use it. For most routine cases, again, asynchronous consultation may actually be preferred. It's certainly easier to send images and to send data and spend more time kind of describing a case using an email than it is sitting on a phone oftentimes. Also, by sending the email, our consultants have an opportunity to really think maybe at a longer time period about what the problem is that you are presenting them, and they may be able to develop better or more courses of action or broader width of differential diagnoses. Certainly for the urgent and emergent cases, voice communications plus or minus sending information asynchronously with email or text is valuable. And then video teleconsultation, and this is a Jeremy Pamplin opinion at this point. I think the video teleconsultation is likely, it's most likely needed or maybe even required for procedural telementoring. So interactions between consultants and so procedural telementoring and consultations or care that is provided by the remote expert directly to the patient. So direct-to-patient virtual care probably requires video teleconsultation. Go to the next slide, please. Okay, so just to close this up, some key takeaway points for telemedical support in the operational environment. I think it's important to, again, emphasize that telemedicine is not about the technology. It's really about the people. Training, practice, planning will all optimize patient outcomes, and they will all optimize how you perform teleconsultation. Whenever possible, using the consultant or the remote expert in your training development will help provide the best I think, training environment, but it will also help with the medical decision-making process on the ground, particularly when an individual lacks the experience in a particular area. A consultation can be extremely helpful and really should occur. It happens every single day in our hospitals, and there's no reason it shouldn't be happening in our remote deployed environments as well. So again, I encourage people to ask for help early and often. The technology side of things really need to remain flexible, scalable, convenient, reliable, and consistent. That means that we should not focus our technology on one solution, but really we should provide capabilities that can adapt to whatever network resources are available to the person on the ground. Those types of technology should be scalable for one or many patients if possible. The technology, that whatever technology you plan for, really needs to be convenient. If it's not convenient, we won't use it. So if you don't know the kit, if you've never used it before, you probably won't break it out when you're in an emergency. The technologies need to be reliable, so every time you go to them, they need to be able to be utilized, and they just need to work every time. And hopefully, as we grow these solution sets across the enterprise, they will become more consistent across across the telemedical system. And with that, I will pause and where I will stop and see if there are any questions amongst the group. So yes, ma'am. So the question was, is the advisor line active? And the answer is absolutely. The phone number is on the slides, and if you it's also being distributed amongst a variety of chains of command. So if you need to call it, you're welcome to do so. If you just want to call and test it and not actually connect to a consultant, that is also an option. You can just call it up and work yourself through the menus. You just don't let it ring all the way through to the consultant, so they don't have to pick up and again, all the consultants that are on the advisor system are otherwise engaged in regular everyday clinical business. So a lot of just practice calls will be distracting to their everyday work, but certainly you pick up the phone, you can test it and see how the menus work for yourself. Sure. So I don't know if I heard a question necessarily in that, but appreciate the your praise for the lecture. The CBA I am familiar with, so capabilities-based assessment. And it's probably just worth everybody knowing that if you want to be involved with that or you have some particular insight, you're welcome to email the people that are on that last slide there, myself, Major Dan York, or Lieutenant Colonel Sean Hipp. Certainly there's plenty of other folks you can get in touch with to include your chain of command that can try to move information up to us, but those are probably the fastest three people to ping to hopefully get information into that assessment. I want to comment on one more thing with relationship to the advisor toll-free number. Some people have trained with and are currently using some other previous numbers to include the virtual critical care consultation line and the STS3 numbers. Those numbers are still active and will not go away anytime in the near future, maybe not forever. They just link into a portion of the overall advisor call tree. So the toll-free number hits you at the top, the VC line just hits you at option 1, and the STS3 line enter the system at option 2. Any other questions? That's a great question. So just to repeat the question, it was, what is the future of growth for the advisor consultants? And the comment was that as the consultant pool grows, the system will become more robust and able to essentially follow the sun with who's on call at any given time. Yeah, so again, that's a great question. I think there's a couple pieces to address in it. The first is there really is a balance between the number of consultants that are available on the system and their skill set at providing consultation in the context that we were asking them to provide consultations. I don't know if you've ever had the experience when you call up a consultant and they provide you recommendations that are just simply not possible to follow, or they are frustrated with the caller because the caller doesn't have the resources that the consultant wants them to have in order to do the recommendations that they want them to do. One of the things that hopefully all the consultants that are on the advisor system now have learned, we certainly have tried to train them, is that you always provide the help that the local person needs, not the help that you want to give them. And providing that consultation and context, again, is a skill set. And the more rapidly we expand, the harder it is to make sure that all of the advisors that are on the system have that knowledge and expertise and that training so they give the appropriate consultation and context. I think that as we are expanding already, there have been a couple of reports of that type of a challenge, and we just need to be very focused on that we don't expand too quickly, but we also want to be conscious of what you said is the faster we can get more people on board, the more volume and frequency we can handle. That being said, the future growth right now is really kind of tied to some of the approval processes, some of the higher headquarters, to allow more consultants from across the enterprise, so different regional folks to be involved in the system. Obviously, there's a balance between providing beneficiary care and then providing this type of consultative care to our operational environments. I think that the current messaging from our leadership is certainly in favor of providing consultation to our operational forces when we need it, and that is a priority. But it's difficult sometimes to move the slow-moving ship of both MedCom, BUMED, and Air Force Office of the Surgeon General to support these types of operational efforts when the focus for so long has been on garrison and beneficiary care. Again, I think the conversation is certainly going in the right direction with that right now, and people are very supportive, but some of the documentation is still catching up. Hopefully that answers your question. So the question, great question again. So the question was about continuity. So if you make a consult, is that same consultant, remote expert going to be available, 7 to 8 hours later when you want to re-engage them? Certainly, And I think this is a great aspect to bring up about training versus real world. When we have done most of our training calls, most training is done as a single phone call to the consultant, and usually it does not involve follow-up. All of the real world events that we have been engaged with have required at least one follow-up phone call. So the continuity question is really important. Right now, just with the volume and frequency of calls, the consultants, generally speaking, are on call long enough. They're usually on for several days at a time. So if you call back into the system, you usually reach the person that you were talking to before as it currently stands. Obviously, that may change in our future with higher frequency and volume. But if you look at the call scripts that we have been providing, one of the first questions on the call script is, what's the best contact information for you? And we tend to train, or we train our consultants or advisors to provide their personal phone numbers so that you can do with the continuity that you're talking about. So once you've accessed the system through a generic number, ideally you would get individual numbers so that you could do exactly what you're asking for, which is to call the same person that you've already talked to back. One other interesting way of doing this is how both the asynchronous systems that are currently in play do it. So the AKO email system, as well as the Path or Help portals, they all send their messages or their cases to a group of consultants, and then the replies for those cases go to the entire group as well. So the whole group essentially maintains situational awareness of ongoing consultations. That's, I think, a nice way of doing it. It's a little bit harder to do that, obviously, with synchronous consultations. But if you look at our best practices, whenever possible, you should try to send asynchronous communication along with synchronous communication, because it usually ends with better patient outcomes or better consultation, better recommendations from a consultant, and better understanding from the local caregiver. Hopefully that answers your question.
That's it for today's podcast. Be sure to go to our website, www.prolongedfieldcare.org. Find us on Facebook, YouTube, Instagram. Subscribe and stay on the bleeding edge of combat medicine. This is Dennis for the PFC Podcast. Hurry, boys. That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC Podcast, out.